Welcome to this month's Team Phenomenal Hope Support Group meeting. I'm so happy you guys could all be with us. I'd like to begin by thanking our generous sponsors, Johnson & Johnson, CVS, Merck, Gossamer Bio, and Liquidia. Without them, some of our resources would not be possible, so we definitely appreciate their support. I'd like to point out that Team Phenomenal Hope has a lot of great programs that you should take note of. One of which is the Unmet Needs Fund. That's supposed to help with like non-medical expenses. It's something that you apply for once a year. It's a great resource that's available to all of our PH patients. If you go onto the website, which is teamphenomenalhope.org. You can apply, and they just ask for like a photo, a little bit of a blog piece, and they'll award a one-time scholarship to help with non-medical, non-prescription needs. Gas, groceries, whatever you might have to cut back on because of medical necessities. One of our other programs is the Let Me Be Your Lungs, which is basically run walk events where an athlete sponsors you and they participate on your behalf in order to raise awareness for PH. It's a great program. You can have actually friends and family like do different walks and help raise awareness. It's a fun way to get your friends and family involved and athletes that you might know. We also have a peer-to-peer program. So if you are looking for one-on-one support beyond just this support group, we have 10 different peer supporters that you can match with. I am a peer supporter, and there are, of course, 9 others. You can see their bios on the website and read a little bit about them, see if maybe they might be a good fit. If not, you go ahead and try a different peer supporter. Our job is to be here for you guys, if for whatever capacity that we are able to. And sometimes you just need somebody that you can vent to that knows exactly what you're going through. Let's see here. I want to make sure I'm hitting everything. Wednesday, November 19th, we will be having a webinar that teaches you to navigate the National Institute of Health website and other resources. That'll be Wednesday, November 19th at 7 p.m. Eastern Standard Time. To register, go ahead and select the link that's in the chat. Peer-to-peer support group program is also in the chat, the link for that. If you missed the town hall webinar, it will be posted soon. This webinar discussed navigating the disability process and much more. So I definitely advise checking that out once it's posted. Go ahead and leave your email in the chat if you would like the link when it becomes available. Finally, when this support group meeting is done, afterwards we'll be sending out a survey to everybody because we would love your feedback. We want to know what worked for you, what didn't work for you. This is your way to voice and have some say in how we do things going into the future. So we definitely would love to hear any kind of feedback that you have concerning this meeting. The next support group meeting is going to be in January. And at that one, we'll be discussing insurance, financial resources, and policy changes with Marcy Hoffman of CVS Specialty Pharmacy as our guest speaker. I've heard her speak before. She is incredibly knowledgeable, very friendly. I think you guys will love her. Before introducing our next guest, I would like to note to everybody that while we encourage questions, our guest speaker can neither diagnose nor give individualized medical advice. Um, with that being said, I would like to introduce our guest speaker, Dr. Pradhan, who is a PH specialist at Tufts Medicine in Boston, specializing in pulmonary hypertension.
Thank you so much, Kira. Good afternoon, everyone. Thank you so much for having me here today. I am so excited to be talking to all of you about a topic that is very dear to my heart and that I'm very passionate about. Kira kind of mentioned I am a pulmonologist with expertise in pulmonary hypertension. I work at Tufts Medical Center in Boston, in Massachusetts. And um, I'm going to go over a brief presentation. The goal of this presentation is to review some key concepts and provide a general framework. And then I'd really like to open it up to questions. I've tried not to put too much information in the presentation so as to not overwhelm people, but to provide, a context to keep it relevant. So with that, I think I'll get started. I think everyone can see my slides. So in today's session, we're going to be reviewing what the WHO groups of pulmonary hypertension are. Now, some of you may be familiar that pulmonary hypertension is subdivided and by the World Health Organization. And so that's what we're going to be going over today. We'll also be reviewing, in brief, what the definition of pulmonary hypertension is. We'll talk a little bit about why and how pulmonary hypertension occurs. We'll discuss some common symptoms, and then we'll do a deep dive into the WHO classification system. Now, to start out, what is pulmonary hypertension? Now, simply put, it is a condition where the pressure in the lung circulation is increased. And, here we have a diagram. What we see in the middle, let me see if I can get a laser pointer. Okay, are you able to see this, everyone? Yes? Okay, awesome. So here we have the heart. We have the two lungs on the side. We can see that blood comes from the body into the right side of the heart, which is highlighted in red. It goes from the right upper chamber to the right lower chamber and then into the lung arteries, where blood then goes to the lungs. Now, when the pressure in this lung artery is high, that's called pulmonary hypertension. And now, typically, the right side of the heart is not used to having to pump against such high pressures. It is the smaller and the weaker compared to the left side of the heart, which is used to pumping against higher blood pressures in the body. So when pulmonary hypertension is uncontrolled or untreated, it can cause the right side of the heart to be stressed out. This was a study that was done that essentially surveyed patients and looked at what were the most commonly reported symptoms. And I think someone mentioned the first symptom of shortness of breath, which is, the most commonly reported symptom in pulmonary hypertension. You have touched upon, I'd say almost everything and more that is on this slide. There's, this slide is not completely comprehensive, but yes, people can be dizzy, they can have fatigue, you can have chest tightness or chest pain, swelling or edema, like people mentioned. So you guys are on point. So now that we have a little bit of an overview, we can talk a little more about what are the types of pulmonary hypertension and who is who. So who in this case is the World Health Organization. And I was looking I actually wanted to find the original Dr. Seuss picture of Horton Hears a Who, but I guess they made it into a movie. So this is what I found. So we'll be using, moving on to the next section. And, in order to understand the types of pulmonary hypertension, I think it's important to first understand why pulmonary hypertension occurs, and then we can use that as a basis to talk about the different groups. So at a cellular level, under normal conditions in the lungs, there are substances that cause lung vessels to contract and become narrow. There are also some substances that make your lung arteries relax. And normally, both of these substances are present in perfect harmony. They're in the perfect amount so that your lung arteries are open and they're able to receive all of the blood supply from the right side of the heart. But when people develop pulmonary hypertension, what happens is that there's an imbalance in these mediators. And the mediators that make your lung arteries become narrow and thicker are increased. And so vessels tend to become narrow. You'll notice that the wall of this vessel here is a lot thicker, and that's because the muscles in that vessel are increased. And there can even be tiny microscopic clots. Now, this is not visible to the naked eye, but under a microscope, you can see small clots within these vessels. And overall, this contributes to pulmonary hypertension, causing the pressures to go up. So if we review normal circulation, then we can review what is abnormal and what happens. And so we did cover this a little bit in the first slide, but I'll review. So blood comes from our body, and let me explain this diagram here. The blue here is the right side of the heart. I know it's confusing, but when people draw diagrams, they flip it. So this is the right side. The red here is the left side. So blood comes from your body. It goes to the right upper chamber called the atria. From there, it goes to the right lower chamber. From there, it goes to the pulmonary artery or the lung artery, which takes blood to the lungs where it gets rid of carbon dioxide. It picks up oxygen. You can see the blood going from blue to red, indicating oxygenated blood. And then it goes to the left side of the heart, left upper chamber, left lower chamber, and then it gets pumped to the rest of the body. Now, different things can cause pulmonary hypertension, and that's why knowing about the groups is so important, because sometimes if you just Google pulmonary hypertension, you only read about a certain subtype called pulmonary arterial hypertension, which I'll talk about. But it's important to know about the different causes because that actually plays into the different groups of pulmonary hypertension. So if the left side of the heart doesn't work the way it should, meaning there's heart failure of some kind, and we'll review this in more detail, this can actually cause fluid to back up into the lungs and into the lung arteries, making the pressure go up. And this is called group 2 pulmonary hypertension. And the WHO organization has a total of 5 groups. I'm going to come to group 1 at the very end. We'll start with group 2, which is where in the left side of the heart is impacted. Sometimes people may have lung disease, which we'll talk more about, but having lung disease can also give you pulmonary hypertension, and this is called group 3. At times, people may have blood clots in the lungs, and these obstructions or blockages over time can also lead to pulmonary hypertension. And then lastly, there's a very specific group of pulmonary hypertension called pulmonary arterial hypertension, or PAH, which is a disease of the lung vessels itself, where the lung vessels, the lung arteries become thicker, they become more muscular, they become more constricted, but it's not happening secondary to something else in the heart or the lungs. So that is group 1. And are also called PAH. And we'll be talking a little more about all of these groups, but this is just to give you a kind of an overall landscape of how things work. Now, I wanted to show you guys this slide mainly to talk about the prevalence, which means how common are each of these types of pulmonary hypertension. And you will see the most common form of pulmonary hypertension is actually pulmonary hypertension associated with left-sided heart disease, or group 2. Thereafter, the most common is typically lung disease causing pulmonary hypertension. And then you will see that group 1 pulmonary hypertension, or PAH, is actually rare. Yet if you Google, that's probably the first thing you'll see online. So this is just to provide context for people. Pulmonary hypertension caused due to blood clots in the lungs is also rare. And then group 5, which I haven't touched upon so far, basically includes types of pulmonary hypertension wherein there are either multiple causes, multiple factors play a role, or we don't really know why people have it. So that falls under group 5, which is a catch-all bucket. So why does this matter? Whether you're in group 1 or group 2, how does this impact your care? How does this impact how you do long term? And for one, the groups of pulmonary hypertension are split to a certain extent into the underlying cause. So it helps give people an idea. If someone tells me, oh, it's largely group 2 pulmonary hypertension, I know to think, okay, this is largely because of the left side of the heart. It also predicts the response to treatment. So different medicines in pulmonary hypertension are approved for different groups. And so the medicines that you may be eligible for often depends on the group of pulmonary hypertension. And the overall treatment principles are also guided by these groups. And I can tell you a little more about how this varies. I don't want to get into too many of the weeds because this talk is not focused on treatment, but treatment does vary based on groups. And then lastly, it can also inform prognosis, which means what is the expectation for how people will do long term? And having a sense of these groups can also help inform these decisions. So let's start by looking at group 1, which is called pulmonary arterial hypertension, or PAH. There are many causes. I'm going to go through some of them. I don't expect you to remember this, but this is just to give you an overview. People can sometimes have hereditary pulmonary hypertension, which means this is inherited. There are genetic abnormalities in the genes that leads to this. It can be idiopathic, and idiopathic is essentially a word that means we don't know why people have this, but we are seeing that there is pulmonary arterial hypertension in this group. Sometimes there are certain genetic mutations associated with this, and this may not be inherited. Connective tissue disease is another big group that constitutes group 1. And connective tissue diseases are diseases like rheumatoid arthritis, scleroderma, lupus. These are diseases some of you may have heard of. And oftentimes, these diseases can be associated with pulmonary hypertension. HIV can also cause pulmonary hypertension. Liver cirrhosis, for various reasons, may cause this at times. And then certain toxins and drugs. This is, the list is long, but what a commonly seen cause is amphetamines, recreationally used, or actually back in the 70s, when medicine was far less regulated and we really didn't know a whole lot, physicians prescribed medicines to women to help them lose weight. And some of these medicines actually contained amphetamines in them. People just had no idea that's what they were taking. And we do see that it can lead to pulmonary hypertension down the road as one of the causes. Now we'll move on to group 2 disease, which is pulmonary hypertension due to left-sided heart disease. And this can be seen when there are valve issues. So either you have valves that are very tight or they're very leaky, and this can cause pressure to back up into the lungs, causing pulmonary hypertension. And then you can also have heart failure. And there are 2 kinds of heart failure here, really. Normally, when people think of heart failure, they think of the heart being weak. The heart is not able to squeeze adequately. And that is one kind of heart failure. And that's sort of what people typically think of as congestive heart failure. However, the heart, in addition to pumping, it also needs to be able to relax so that it can fill with blood. And some kinds of heart failure actually are such that the heart is not weak, but it's stiff. So it can pump fine, but when it comes to relaxing, it's stiff and it can't relax all the way. Another word for this is diastolic heart failure. And this can also cause pulmonary hypertension. There are risk factors for this, like uncontrolled high blood pressure, high cholesterol, sleep apnea, kidney disease, atrial fibrillation, diabetes, getting older. mean, male is a risk factor. Um, so all of these things can sort of contribute to diastolic heart failure, which can cause pulmonary hypertension. Group 3 is pulmonary hypertension due to lung disease. And some of the commonly seen lung diseases are COPD, constituting emphysema, chronic bronchitis. Smoking is a very big risk factor for this. There's interstitial lung disease, which is essentially lung fibrosis or lung scarring, which can lead to pulmonary hypertension. There's sleep apnea, which can also contribute to it. Because with sleep apnea, your oxygen levels actually decrease at night when you sleep. And the lung artery's response to low oxygen level is it contracts. When it contracts, the pressure goes up. And when this happens repeatedly over time, it can cause mild pulmonary hypertension. And lastly, if any of these conditions or other conditions cause low oxygen levels, you have that same response of the lung artery contracting, causing the pressure to go up, leading to pulmonary hypertension. And so this is group 3 disease. And then group 4, again, like we went over previously, not very common, but if you have an obstruction in the lung artery, and this is most commonly caused by blood clots in the lungs. Over time, these blood clots, they, under normal circumstances, if someone has a blood clot in their lung, and if it's diagnosed, then you go on a blood thinner, which prevents more clot from forming, and the body then dissolves the clot that's there over time. But sometimes this clot that is lodged is not dissolved over time, and it kind of gets adherent to the vessel wall, and it becomes very reorganized and tough, and that can contribute to pulmonary hypertension. There are some other causes. Sometimes tumor cells or cancer cells can go in and clog up the lung arteries, leading to a similar condition. But that is the less common in this group of pulmonary hypertension. And then lastly, we have group 5, which was a bucket where if things didn't fit neatly into the first 4 groups, they kind of put them into group 5, wherein either we don't know why it's happening or there are so many contributing factors. And so examples in this group are sarcoidosis, for example, where patients can have lung fibrosis. They can have actual, pulmonary hypertension, wherein the lung arteries are independently thicker and more muscular. It can be sickle cell disease that can sometimes impact the left side of the heart. It can also cause blood clots in the lungs. It can also cause pulmonary hypertension independently. And then, another example is leukemia. So there are more than this in this category, but this is sort of like a catch-all for some of these groups that end up here. And I want to point out that a patient can be in more than one group. We have textbooks written about all of these groups very neatly, but our patients don't read textbooks and come in, right? Your body is going to do what it needs to do. And so people often will have both heart disease and lung disease. So in that case, they are group 2 and group 3 pulmonary hypertension. And so, you may not fit neatly into one bucket. And that's why, you need more, patients need more investigations to be done to try to tease out, is it really the heart? Is it just the lungs? What is the primary driver here? All to determine how can we best treat this patient. So this was just a brief overview. This is my cat Blossom. She's we call her our agent of chaos. So I would love to open it up to questions that any of you have. This is not, I haven't given the most detail, but I really just wanted to give you like a kind of a framework to think about things. I think these, it can be very complex at times, and even for us as doctors, as PH specialists, we really have to think about what is the primary driving group. And yeah, people actually do have group 1 and 2 together, especially when there's autoimmune disease like lupus, scleroderma. Not uncommon to have a group 1 component from that, but a group 2 component. And you're right, it is, usually people will have more risk factors for group 2 disease or heart failure. But it's hard for me to speak to your specific case without seeing you and examining you. And so I do want to preface this by saying that I'm probably not the best person to give you medical advice about this, but I will say yes, we do see it. People do get abdominal swelling or belly swelling, which I know you had reported as one of your symptoms. Some people just tend to hold on to fluid in their belly. Other people hold on to fluid in their legs. It's not uncommon. And then as far as what to do, so it can be very challenging, and that's where knowing what your catheterization procedure numbers look like, knowing what your echo looks like, knowing what your symptoms are, and the timeline can help. But in general, for group 2 disease, wherein it's left-sided heart failure driven, the main treatment is to treat the underlying causes. And then the pulmonary hypertension is treated because the pH in that case is a fallout of the left sided heart disease. And if someone has predominantly group 2 pH, you usually don't want to put them on medications that relax the lung arteries or pulmonary hypertension specific medications, because there have been studies done that have shown that patients actually do much worse. And the last thing we want to do is to cause harm. So, um, I don't know if I can answer the very specifics of your question, but I can say that yes, they do coexist. These cases are very complex. But it sounds like you're doing the right thing by seeing a specialist to get more help and another opinion.
Well, and it
Thank
sounds
you.
like if I'm interpreting this correctly, that when you're in two different groups like that, group 1 and group 2, for example, that even though normally people would get treated with group 1,
Mhm.
that sometimes actually ends up hurting things because you're in group 2.
Yes.
Oh,
Yes,
wow.
that's a good Yes, that's right. We didn't talk about this previously, but typically for group 2 disease, you want to be very cautious about using um, medicines that relax the lung artery, because essentially what happens is that if you relax your lung arteries, now they're very dilated, and now there's more blood going to the left side of the heart than the left side of the heart can handle. It's not used to having to deal with so much because it's not working the way it should, because there's heart failure or the valves aren't working, and that can cause fluid to back up into the lungs. And patients get what's called pulmonary edema or fluid in their lungs. You're more short of breath, and so that's absolutely right, Kira. People are in two groups sometimes, but you always have to consider, you know is there harm to putting them on this medicine? And with group 2 disease, it can be very challenging to find the right balance.
Yeah, that makes sense. I'd like to just point out again that Dr. Pradhan is not able to give medical advice or diagnose anybody. So just as a heads up. So I appreciate it. I believe Tris has a question.
Pulmonary hypertension, again, spanning a few groups, right? Autoimmune disease makes me think, especially with what you're saying, like there are definite group 1 risk factors. But if you had interstitial lung disease or lung fibrosis, diseases can also cause, you may have a group 3 component. Um, and then the other question is, why are you still so short of breath if your CT scan is better? So I guess there are many things to tease out over here. Um, I think this is another example of an overlap of like 1 and 3. Antiphospholipid syndrome, you're absolutely right. It is a vasculitis syndrome wherein you get actual inflammation of the vessels, and it can make people prone to blood clots sometimes. Um, Potentially adding a group 4, but doesn't sound like that's the case with you. But that's just something that we kind of need to be aware of when we're thinking about these diseases. As far as, can you make a distinction between what is causing the pulmonary hypertension? Is it inflammation from autoimmune disease, or is it from the vasculitis, or is it the lung disease, or is it PAH? And I guess the answer is, it's hard to say, because we don't typically tend to biopsy the lung arteries because it's a very dangerous thing to do. It's, potentially life-threatening. I think it would be a little unusual unless the reason for his lung fibrosis is some kind of autoimmune disease or vascular also increases your propensity to clot. So hard to say, but off the bat, I would not associate lung fibrosis and stroke or pulmonary hypertension and a stroke.
Okay, thank you.
Yeah, that's a really good question. And I think the honest truth is we don't know a whole lot about sarcoidosis. There are a lot of hypotheses as to why people get sarcoidosis, what happens at a cellular level, but we don't have any great answers. And sarcoidosis can impact multiple parts of the lungs, which is why, yes, sarcoidosis does impact the immune system, but not in the same way that autoimmune disease does. And so it's sort of been given its own special bucket, in part because we don't know exactly how it's doing this. And then the other reason being because it impacts more than one part, like it can impact the lung arteries, it can cause lung fibrosis, it can cause obstructive lung disease wherein your airways become tight, just because it can do so many things and cause inflammation in different places. That's why we think it's in group 5, but I don't think I can give you a satisfactory answer to this question, unfortunately. And even us in medicine, we're stumped. Yeah, no, thank you. Thank you so much for your question. I'm so sorry that you're going through this. Sarcoidosis can give you body aches in a couple of ways. So one, sarcoidosis can impact the joints, and actually cause inflammation in the joints. And so that's one potential mechanism. Myositis, or like inflammation of the muscles, not as often seen, but it can impact the tendons at times. And so, are you getting a little bit of sporadic inflammation? Or is this your body's response to inflammation elsewhere? Sort of like when you have the flu, you kind of get aches and pains all over. Hard to know. A PET scan, if these symptoms are persistent and you find that, there's persistent knee pain or persistent ankle pain and it like isn't going away and it's constant, then a PET scan can be helpful in determining if there's inflammation there or not.
I have a quick question about group 5. I've actually was not familiar with that at all. And it says that you said it was for multiple disorders. So if you have pneumonia, if you have pulmonary hypertension based on multiple disorders, then how do you treat it?
Yes, and I can clarify a little bit. What they mean by multiple is that it's multifactorial, meaning there are many underlying causes that lead to pulmonary hypertension. So one disease, we can take sickle cell disease as an example, because that is in group 5. And sickle cell disease can do a number of things. One, it can impact the lung arteries themselves, giving you more of a typical PAH picture where you get pulmonary hypertension because of that. As people with sickle cell are living longer because we have better treatments now than we did, 30, 40 years ago, we're seeing that as you get older with sickle cell, the left side of the heart gets impacted and you end up with stiffness on the left side of the heart. So that can also cause pulmonary hypertension from a group 2 sort of, mechanism of action standpoint. And then sometimes, patients with sickle cell, they can get, what's called these pain crises, and you can get a lot of inflammation with in the lungs sometimes. And if this keeps happening repeatedly over time, people can even have lung fibrosis. And because the mechanisms are so complex and it impacts so many systems, they're called multifactorial and they end up in group 5. The treatments for group 5 are not this is sort of where going to an expert and being at an expert center matters. We do have treatments for patients that have sickle cell disease and pulmonary hypertension, but there are certain medicines we know we cannot use in this group. Like for example, we're not supposed to use one of the oral medications, and so we know some things about this, and the treatments for group 5 kind of depend on what we know about group 1 disease and what is their presentation more. Is it more the heart? Is it more an actual lung vessel pathology? And then we kind of borrow from group 1 to determine, do we treat it like group 1, or is this patient, I have someone with sickle cell disease who has been on an oral medicine for pulmonary hypertension most of his life, but now he's older and he actually largely has problems with the left side of his heart. And so we're trying to decide, do we keep him on this medication or do we get him off? Is it actually more harmful for him at this point to be on it? So really good question. It's either we don't know why people have PH or they have too many things contributing to their PH, and people didn't want to put sickle cell into group 1 or into group 2 or into group 3 or into group 4 because they also get blood clots. They said, let's just put it in group 5 because there are too many things playing a role.
Awesome. Thank you very much. That's actually much clearer. Thank you.
Thank
I
you.
do have a further question actually concerning group 1.
Mm-hmm.
When I was first diagnosed, I was diagnosed with idiopathic.
Mm-hmm.
This past year, my mother got diagnosed, so now they think it's hereditable.
Hereditary. Wow.
So
Oh my
you had
goodness.
talked about it being a gene mutation.
Mm-hmm.
Have they identified what that gene mutation is? And can they identify it? Like, is there a test that the rest of my family could take to see if they are prone to it?
Yeah, that's a great question. And there are some mutations that are better defined. A common mutation is the BMPR2 mutation, um, which sometimes patients will get genetic testing for. But it actually would be worthwhile if you have access to a genetics counselor or a genetics department to actually be seen by someone over there, and they can send off a panel. There is a genetic panel for pulmonary hypertension. So if both you and your mom did it, you could potentially see where there was, if there's a culprit gene, and that actually might help inform screening for your family. And a genetic specialist will be able to counsel you about what the mutation is and what the recommendation is for screening as well.
Very cool. Thank you. Yeah, until this past year, I didn't even know it was hereditary. So
My goodness.
I didn't even know that was a thing. So I appreciate your information.
Of course.
Let's see. We have a question in chat from Tris. I'm scheduled for a CTA coronary artery scan. Why is nitroglycerin dangerous for PAH-PH patients?
Okay. Really good question. Nitroglycerin comes up in a few contexts. And there are two reasons. One, nitroglycerin tends to cause or can cause a big drop in your blood pressure because it largely causes the veins to dilate and relax. And in patients that have pulmonary hypertension, if there's a sudden change in blood flow, a sudden drop in the amount of blood that their heart is getting, it can be difficult for the right side of the heart to compensate. So that's one reason why typically, in someone with pulmonary hypertension, I would be very hesitant, to give them nitroglycerin or anything in that family of medicines. The other thing to be cognizant of is that with pulmonary hypertension, patients are sometimes on a group of medications that are called phosphodiesterase inhibitors. So some examples are tadalafil or sildenafil. And these medications interact with nitroglycerin or nitrates basically, and you can get pretty significant drops in your blood pressure by taking both nitroglycerin and being on this group of medicines. And again, with pulmonary hypertension, the right side of the heart is really dependent on having the right amount of fluid. You don't want too much, but you also don't want too little. And if there's a sudden drop, you could lose consciousness, and it could cause the right side of the heart to fail. And so that's why it's typically not recommended in patients. A similar medicine in this category is Viagra, which we do tell patients that if you're on sildenafil or tadalafil, please do not also take Viagra. It is not recommended for the same reason. Yeah, that is, thank you so much for your question, Jeanette. It's, something that every family, every woman thinks about and is important. Um, the answer to are people not having kids because of sarcoidosis is probably no. I don't think that's the case, but it really depends on a case by case basis because you have to determine what is the risk of pregnancy. And it also depends on, is the sarcoidosis just causing lung fibrosis? Maybe it's mild, maybe it's well controlled, maybe you have a good window where you can go through pregnancy, but you kind of have to be aware of like what are the risks with that. Could pregnancy make it worse? Could it make it better? What are the risks with delivery, which tends to be a very, a time when there are a lot of fluid shifts in the body. So sarcoidosis by itself, it's a little subjective because it depends on what it's affecting and how severe it is. But pulmonary hypertension and pregnancy, women actually are able to get pregnant in today's day and age. Just with the, advancements that we're seeing in pulmonary hypertension therapies. But this is not like a general rule that everyone with PH can go and get pregnant. It's like you really need to talk to your doctors, make sure that they're on the same page. And the goal is to, when we think of pulmonary hypertension, we risk stratify patients. So we determine if they're high risk or low risk or intermediate risk, and you want to be in that low risk category wherein your symptoms are well controlled, your pulmonary hypertension is well controlled, your walk test looks good, your blood marker levels are good, and then it sort of becomes a conversation about what medicines do we get you on to help you go through this successfully. But pregnancy in PH is extreme, it is high risk. It's not like the general population. And so it is a more like nuanced conversation. But it depends, I guess, is the answer. And I think maybe I think it's an important question that you're asking. Definitely talk to your doctors about this to see what they think, because they probably have a much better sense of, your disease and how it presents.
I would also like to mention that next year, we did one this past year, and we're going to be doing it again this upcoming year. Is have a talk about intimacy and pH. That's including sexual health, sexual intimacy with your partners, all forms of sex ed questions. Because trust me, I had some of those very similar questions myself. Especially because with some of the meds, you have to get mandatory monthly pregnancy tests. I am very gay. We have to plan for these things so that, it was a little funny. But yeah, we will be doing intimacy and pH talk. So if your questions aren't answered here, please join us for that one too. I highly recommend that talk as well.
Thank you so much for your question, Marcel. So I guess it depends. Blood clots are not that common. So, if you're someone without a condition that predisposes to you to it, or you've never had a blood clot before, I wouldn't worry about it per se. It's more, that group of pulmonary hypertension, which is group 4, is specifically in patients that have had blood clots. So amongst the few patients that have had blood clots, most of them resolve. They go away. People don't get pulmonary hypertension. A small percentage of people in that group can get pulmonary hypertension. So it's a possibility. It's not like a definitive, if you have a blood clot, you're going to get pulmonary hypertension. It's just if you have a blood clot in your lung, just make sure you get follow-up so that you can keep a close eye on it. For most people, their heart function goes back to normal and they return to normal life. APS specifically with is kind of like a type of lupus, you could say, that does tend to have a higher incidence of clots compared to lupus without APS. Does that mean everyone with APS gets blood clots? No. There are people that don't get blood clots and have APS, but if you have a blood clot, then it would be explained by the APS.
Excellent. Well, thank you. I really appreciate your talk. I actually learned quite a bit, so thank you.
You're
I
most welcome.
was 10 years ago, and like I feel like never know enough. I just so I appreciate your talk and showing us what the different WHO groups are. That was incredibly educational. I would like to thank everybody for joining us, especially Pradhan. Thank you very much for taking the time out of your day to talk to us about all of this. And thank everybody else for taking the time out of your day to join us, because the support group does not work without you. So I appreciate you. I appreciate your time. I would like to point out again that we will be sending out a survey to get your feedback on the meeting. And also, please let us know what kind of topics you want to discuss. That way we can go ahead and bring them up on our meetings and possibly get something, get something along the lines of that, did not word that correctly at all, but thank you. Anyways, thank you for your time. I appreciate everybody, and I hope you have a great end of your year, and Merry Christmas to everyone early. And I will see you guys next year.
Thank you all so much. It was such an honor and a pleasure to be here talking to all of you today. I've had such a wonderful time meeting with all of you guys.